So we're going to do the second last seminar for the neurosurgery series, and it's going to be on the management of neurological malignancies. And since this is the second last seminar, I thought that we should talk about how we're going to issue the certificates for the neurosurgery series. And it would basically be because not everyone must have attended all the sessions, or a very small minority would. We will look at the attendance forms and see who attended the majority of these seminars, and we'll be able to issue them the certificates. So today we're obviously looking at neurological malignancies. So this will be a little bit about neuro-oncology, and so like brain tumors and spinal tumors, stuff like that. And then we'll look at, for our well-being sector, we will look at navigating imposter syndrome, which is also a very prevalent issue. So I guess we'll just get started now, and whoever wants to join can join later on. But yeah, what is neuro-oncology? I think it's very important to kind of define what it is, first of all. So yeah, here is what it is. So neuro-oncology is a specialized medical field which bridges like neurology and oncology. So it's both of them together, and it's focused on diagnosing and treating tumors and spinal cord, like tumors of brain and spinal cords and any other like central nervous system. So any like cancer on nerves and stuff like that. It also covers both primary tumors and secondary tumors. So we'll go a little bit more into what that is. But primary tumors is tumors that actually originate in the brain. But secondary tumors are basically, they came from other places. So the patient may have had it in like their lungs and then it spread to their brain. So, neuro-oncology uses multidisciplinary care like many other fields, such as, so it will focus on surgery, radiotherapy, and chemotherapy. And so we'll be working with a wide variety of different healthcare specialists to kind of treat one patient. And so some main conditions treated are brain tumors, so like gliomas, glioblastomas, meningiomas, stuff like that, and spinal cord tumors and neurological complications of cancer, so like the symptoms and stuff. And the management team include neurosurgeons, obviously, neurologists, oncologists, neuropathologists, neuroradiologists, and clinical nurse specialists, and also allied healthcare professionals, so like physiotherapists and speech therapists, stuff like that. And so diagnosis and care, so it uses advanced imaging such as MRI, fMRI, which we'll go over a little more. It also talks about molecular testing and surgical biopsy to kind of create customized treatment plans. And so treatment modalities can include variety of things depending on what condition the patient actually has. So it could either, be about surgery to remove the tumor, chemotherapy, radiotherapy, or any targeted therapies, which is what the future of neuro-oncology is kind of coming at. And symptom management for like seizures or cognitive issues. So let's say seizures, if the person has very, very like extreme seizures, they would mostly focus on like symptom alleviation because there's not much of a cure for seizures. It's just you can like reduce them. So here's like a little bit of what neuro-oncology looks at. So first we obviously have therapeutics, which is what is most patient-centered. So this is where we're using treatments or treatment methods to kind of cure a patient, or not necessarily cure most of the time, but like to actually alleviate their symptoms. Or we can have diagnostic developments. So that includes like radiology, MRI scans, PET scans, stuff like that. They were obviously developments that were made to kind of help with treatments and diagnostics in neuro-oncology, but also in many other healthcare fields. Then we have biological advances. So this will look at genetic sequencing and DNA methylation profiling. So these are more like towards the biochemistry, biomedical side. So now we'll look at primary neurological malignancies. So these are obviously uh, very important because there are a type of tumors that can occur in the actual tissues of the brain or the spinal cords or any of the protective coverings, such as the meninges. So they're further classified by the type of cell they involve. So there are three main types. Meningiomas is one of the most common primary brain tumor. So this is approximately 30 to 40% of all cases for primary neurological malignancies, and the tumor forms from the protective membranes known as the meninges, which I have a diagram for, and I'll show you. So this surrounds the brain and spine, and these are mostly benign. So that means that they just stay in one place. So that means it's grade one. We will look at the grading system as well in a second. But they can also be malignant. So malignant means that it's cancerous and they can spread to other parts of the bodies, which is known as metastasis. Then we have gliomas. So these are the most common types. So it goes like gliomas, then meningiomas, and then medulloblastoma, which all of these are quite common, but obviously gliomas are the most common. And so they account for about 33% of all brain tumors and about 80% of the malignant ones. So they are very cancerous. And they originate from glial cells, which are the support cells that surround, insulate, and protect neurons. Then we have medulloblastoma, and it's a fast-growing primary central nervous system tumor that originates in the cerebellum. So the cerebellum is like the back and the base of the skull. So it's just like right at the bottom. And this is the most common type of brain tumor in children, and it affects from between ages of 3 and 9. So here is a meningioma. So the meninges is basically this yellow, like pale yellow type of tissue that kind of covers the brain, and the tumor kind of comes up from here. So it grows from the dura and it covers the brain. Then we have gliomas. So they grow from glial cells of the brain, and they can be low grade or even high grade. So it kind of depends on the type of tumor they get. And then we have medulloblastoma, which is a tumor that originates from the cerebellum, and it usually affects children. So having a tumor in the cerebellum is quite, a problem. Getting a tumor anywhere in your brain is a problem, but in the cerebellum, it controls movement and balance and like motion. So, um, a medulloblastoma forming in a child may affect the movement of the child and how, maybe also how they grow and stuff. Then we have secondary neurological malignancies. So we've covered primary and now we're going on to secondary. So they're most commonly known as secondary brain tumors or brain metastasis. So it's a cancerous growth that starts somewhere else and then spreads to the brain. So, unlike primary brain tumors that originate within the brain tissue, secondary tumors are composed of cells from the original primary cancer site. So, most of the time, this is lungs or the breast. And then these tumors then develop when cancer cells break away from the primary tumor and then travel through the bloodstream or lymphatic system to the central nervous system. So let's say a patient has a cancer in their lungs. So the blood flowing from that, passage where the tumor is, it might kind of like transport the cancer cells through the brain, and those cancer cells then start dividing in the brain, and then that forms a secondary tumor. So they're significantly more common compared to brain tumors, like primary brain tumors, occurring up to 10 times more frequently. So as I just explained here, so you could most of the time it's usually lung cancer, brain cancer, or skin cancer that kinds of metastasizes into a secondary brain tumor. Then we have WHO grading system. So this is the grading system that we use to kind of scale how malignant a person's tumor is. So it most commonly refers to the WHO WHO classification of tumors of central nervous system. So WHO is basically World Health Organization. So they set up majority of the policies and just like protocols for healthcare around the world. So this is the international standard for categorizing and grading brain and spinal cord tumors. So the system uses a malignancy scale to predict a tumor's biological behavior and guide treatment. So, grade 1 is slow growing, non-malignant, and it's usually just a benign tumor, which is usually just curable with surgery alone. So, the surgery will focus on the resection of the tumor. Resection basically means removal of the tumor. Grade 2 is a relatively slow growing but infiltrative. So that means that it can potentially metastasize and spread to the rest of the body. And they can also reoccur. So sometimes, after resecting the tumor, sometimes if it's a grade 2 tumor, it may reoccur and sometimes progress to higher grades, so like grade 3 and 4. Then grade 3 is malignant cancerous tumors with actively growing cells and abnormal appearance, often called anaplastic. So they're growing, they're expanding, and they are usually malignant, so they spread to the rest of the body. And grade 3 type of tumors are more likely to kind of spread to the rest of the body, and this is where the cancer starts to get highly aggressive. Then we have grade 4. So this is the worst, the most aggressive type of tumor that a person can get. And it's rapidly reproducing malignant tumors with areas of dead cells, which is also known as necrosis. And this is often associated with poor outcomes. So in terms of poor outcomes, it basically means that the patient may die. Or may not recover fully. So they have a poor prognosis for instance. So here's like a little bit of a chart of the WHO grading system for gliomas especially. So we have obviously non-tumor, so this is just normal brain tissue. Then we have grade 1, grade 2, grade 3, and grade 4. So grade 4 is like the worst type of most malignant, and it's very infiltrative and it's very fast growing and it's a poor prognosis. Grade 3 is mostly just malignant and infiltrative, so not as much as the grade 4 one, but it's still really, obviously harsh. And it has a high cell density, meaning that it's quite a big tumor. So having a big tumor may also impact the, um, like nerve pathways or maybe bloodstream pathways. And that's why it's quite important to remove grade 3 or grade 4 or even any type of tumor. And yeah, so that's just something I wanted to add. Then we have diagnosis of brain tumors. So, first of all, whenever you kind of like when a patient presents with any type of neurological symptom that may be sudden loss of vision or hearing, because obviously the brain, like controls most of these senses. So if you just suddenly lose it or you're experiencing partial blindness or partial deafness, then you are obviously going to present that to the hospital and a neurological exam would be conducted on you. So it usually just tests your central nervous system and like the processes it's going through and different parts of your brain to see if they're working. So this exam would include like checking your vision, testing your reflexes, asking simple questions to kind of test your memory or cognition, checking your hearing, checking your balance, coordination, and strength, and finding out if you have any numbness or odd sensations or weaknesses or any seizures, or if you have any problems with moving in a certain ways, because that could, indicate paralysis. And a neurological exam doesn't detect a brain tumor, but it helps your healthcare professionals or GPs to understand which specialty to kind of refer you to and what part of the brain may be causing those symptoms. Then obviously, after a neurological examination, you might not be fully convinced that it's a brain tumor, so then you need to perform more checks. Um, so if you present with any issues, they would rule out, like, they will maybe consider that you may have a brain tumor or any neurological condition or disorder, such as like Alzheimer's, if you have any, problem with memory, or epilepsy, if you have like loads of seizures or anything like that, etc. So the other type of so after the primary neurological examination, um, and if you get referred to the neurologists at the hospital, then they may perform a computed axial tomography. So this is known as CT or CAT scan. So CT scans use X-rays and a computer to create detailed pictures of inside your body, right? And so a CT scan can detect problems in and around your brain. And so this results gives like your healthcare professionals clues to decide what to test next, or what diagnosis you may have. So you might have a CT scan of the brain to kind of help diagnose a brain tumor. If you need, if you need to have an emergency scan to kind of decide what's causing your symptoms, because the brain is a very complex organ and it may have a lot of conditions that it could be, going through that is causing the symptoms. So, yeah, and you're unable to have an MRI scan. So, for example, you have a pacemaker. So, a pacemaker is just a electrical device that's put inside your heart to kind of regulate your heartbeat. So that is if you have like atrial defibrillation or like some kind of heart issue with your regulation of the heartbeat or heartbeat rhythm. So you can't have an MRI scan if you have that, because um, obviously the MRI scan, magnetic resonance imaging, uses magnetic fields, so it might have an impact on it might like knock out your pacemaker from its place, and then that's going to have an effect on your heartbeat, and that might be quite dangerous. And then your doctors may want to look at the bones close to your tumor as well. So that's also, you might have a CT scan because of that. You might have a CT scan of your tummy or abdomen and chest to kind of check whether you have cancer anywhere else in your body. So if they find a cancer in some part of your body, they will make sure to check the rest of it to make sure it's not metastasized, or it hasn't spread. And this is to see whether the tumor, yeah, if it's spread. So yeah, then we have MRI scans, so magnetic resonance imaging. So we just talked about this. So it uses magnetism and radio waves to take pictures of the inside of the body. So just to make it clear, MRI scans, CT scans, all the type of scans, they're not just for the brain. They're used for many different things, many different parts of the body. But obviously, because we're talking about neurosurgery, neurology, neuro-oncology, we'll be discussing how MRI scans and the other types of scans are used for the brain. So they're often used to detect brain tumors, because it shows the brain more clearly than the other imaging tests. So you'll be able to see the main structures of the brain. So how it goes is a dye is injected into the patient's vein before an MRI. And so this dye helps the doctor see the difference between the brain tumor and healthy brain tissue, and gives them a little more detailed information about how the tumor is likely to behave. So sometimes specialized MRI scans are needed. So there are two types of specialized scans, which are known as functional MRI. So this is where it allows to test for brain control activities such as speaking and moving. So the healthcare professional may tell the patient to kind of do a certain thing to see what activates that region of the brain, and it allows healthcare professionals to plan surgery and treatments accordingly, depending on the type of results you get from them. Then the second type of specialized MRI scan is perfusion MRI. So this shows blood flow in different parts of the brain, and it lets the doctors know which parts of the tumor is most active. So perfusion basically means blood flow. So it helps to see what parts, like blood flow in the different parts of the brain. So if there's blocked blood flow, like slightly blocked blood flow in one part of the brain, that might help decide that maybe there's something like a tumor in that region. So here's a picture of an MRI scan. So you might have seen this big machine. So this uses like magnetic fields and radio waves to kind of scan the brain. Then we have positron emission tomography. So this is known as PET scan for short, and it uses a radioactive tracer that's injected into the vein, so much like the MRI scan. And the tracer then travels through the blood and attaches to the brain tumor. And so this tracer makes the tumor cells stand out on the pictures taken by the PET scan. And then the cells are dividing and multiplying quickly, so they soak up more of the tracer. And so a PET scan may be most helpful for detecting brain tumors that are growing quite quickly, so grade 3 or grade 4 tumors. And so brain tumors that grow slowly, so like the grade 1, grade 2 tumors, they may not be detected by a PET scan. So not everyone with a brain tumor needs a PET scan. It's just to check if the speed of how much the tumor is growing. So to kind of put this all into one scenario is like if a patient comes in and they have shown that like some evidence that they may or may not have a tumor, a brain tumor. After the neurological examination, they got referred to the neurologists, and so the neurologists then did a MRI scan to kind of decide if they have a true tumor, and then to just make any precautionary like decisions, they first do a PET scan to kind of see if the tumor that they've detected is very um like fast growing or if it's like slow and benign. So if there's a positive test for the PET scan, meaning that the tumor is like very, very aggressive and it's growing quite quickly, then they need to take measurements as soon as possible. They need to intervene as soon as possible to make sure that the patient doesn't die. But then if it's a slow growing tumor, they may look at slightly less invasive surgeries or things that will help reduce the progression of the tumor or to help alleviate the symptoms. So obviously brain tumors and neuro-oncology is quite a big field, so it uses a lot of different healthcare professionals, like all healthcare like specialties do. So it's not just neuro-oncology, neurosurgery, cardiology. They use a variety of healthcare professionals to kind of make up something known as the multidisciplinary team. You may have heard of this. This is a approach that the NHS uses as well. So basically, it means a group of healthcare professionals who work together to plan and execute patient care accurately. So this is used routinely across the NHS, especially in cancer services, because the cancer can, spread in other areas of the body, and not everyone will have the specialty training to kind of treat all the types of areas in the body. So they may need help from other specialists to decide on a treatment or like a course of treatment plan. So each specialist then contributes their expertise to ensure that the diagnosis and planning is accurate. Um, and so MDT meetings review like scans, so like the PET scan, CT scans, or MRI scans, and pathology, so the study of the disease and other clinical information such as if the patient has any other type of healthcare condition, such as maybe atrial defibrillation or maybe a family history of cancer or diabetes, stuff like that, to kind of contextualize the patient's case, and then also make sure that whatever treatment plan they make is the most beneficial for the patient. So for neuro-oncology specifically, the professionals that the MDT include are neurosurgeons, oncologists, radiologists, and clinical nurse specialists, and allied health professionals. So they include physiotherapists and speech therapists. So the benefits of using an MDT approach is that it improves accuracy of diagnosis because there is a multiple, like there are many different healthcare professionals that come together and kind of give their own expertise and their own knowledge to make a diagnosis. So it's most likely to be accurate. It also ensures a patient-centered holistic approach, and this aligns very well with the seven guiding principles of the NHS and the six core values of the NHS as well. So this is why the MDT is used. So it reduces delay in treatment as well. So it kind of separates the workload for each patient, and this may help reduce delays in the treatment and kind of make sure that patients that really need like a medical intervention, they can get that as soon as possible. And allow shared decision making to take place between specialists. So neurosurgeons may consult oncologists to kind of decide a type of route they should take to resect the tumor, to remove the tumor. And like radiologists may also consult the neurosurgeon to help them decide or locate where the tumor actually is. So neurosurgeons can't just do it by themselves. It requires a whole team. And so this also provides coordinated communication across services. So first of all, you'd have to go through the primary care, which is the GP, and then the GP will then, consult you to others healthcare professionals. So this is how, we have a holistic approach to patient-centered care. Now we'll look at like the specific roles of neurosurgeons in neuro-oncology. So they assess patients for surgical biopsy based on imaging and neurological status. So biopsy means like they take a sample of the brain tissue to kind of test for certain conditions such as a tumor, or like taking samples of the tumor to decide if it's what grade it is. So if it's a grade 1 tumor or a grade 4 tumor. And so they performing the biopsy will help with the diagnosis because it shows like the tissue, the literal tissue from the brain, which may help decide if the tumor is malignant enough or not for a surgical intervention. And most of the time, neurosurgeons' main goal is to carry out a maximal safe resection, which means removing as much of the tumor as possible while preserving neurological function. So sometimes that means that the whole tumor is not removed if it's located in a very specifically important area, and sometimes they may just remove like a little bit of it, like half of it, and then the other half is kind of risky to remove because it's kind of hard to get to without damaging the surrounding tissues of the brain, which are quite important for basic function. And then they also use intraoperative technologies to reduce risk. Um, so that includes like, technologies to reduce blood loss as well, and manage raised intracranial pressure. So this may be done by tumor debulking, which we'll go over a little bit, and cerebrospinal fluid diversion procedures if needed. So we kind of went over cerebrospinal fluid diversion, procedures in one of our previous seminars. So if you're not too sure what that is, I can explain a little bit, but if you want like more details, then you can check out our YouTube to get the recordings for the seminars that you may not have attended. So, cerebrospinal fluid is basically the fluid that's inside the brain and also in your spine. And so once the intracranial pressure builds up, we need to take out some of it so then the brain doesn't like swell up and have that will obviously, if it swells up, it will have an effect on the patient's function, because it's swelling up, the critical regions are getting slammed into each other, and that might reduce the function that they can perform. So that is what cerebrospinal fluid diversion basically means. So inserting devices when appropriate as well. So a ventricular drain to kind of take out the cerebrospinal fluid, or maybe blood as well if it was a hemorrhage, or a shunt to kind of help with any sort of complications that may have arisen, and then provide post-operative neurological assessment. So they would also follow up the patient to kind of check if the operation went well, if it was successful. And then we obviously communicate operative findings to the MDT to guide further treatments such as like radiotherapy or chemotherapy, or any sort of physical help that the patient may need. So that might include emotional help that the clinical nurses would be in charge of, or any like functional, like physical help, which the allied health care professionals would be in charge of. So like the physiotherapists and speech therapists. And sometimes neurosurgeons also have to consider when a surgery is not appropriate due to the tumor location or patient fitness or risk. So, patient fitness, obviously, if a patient is quite frail, quite old, and they may have multiple different conditions or disorders such as heart problems or any vascular issues, then sometimes surgery is not the most appropriate thing to do, because obviously surgery is quite an invasive procedure, and it may have an impact on the patient more than any good, and it may actually cause more risk to the patient's life. Then we have oncologists. So oncologists, they are cancer specialists, and so they review histology and molecular pathology to kind of guide treatment decisions. They also plan radiotherapy. So this could either be two types of radiotherapies. It could be focal radiotherapy or stereotactic radiosurgery where appropriate. So focal radiotherapy is basically when multiple rays of radio waves are kind of concentrated at one area. So they're shot from multiple different angles towards one tumor, and that for all those angles, they intersect, and then they provide the radio waves that are needed to kind of damage the tumor and kill it. So that is how focal radiotherapy kind of works in a nutshell. Then we have stereotactic radiosurgery. So stereotactic basically means the head is kept still, and then the radiosurgery. It's quite similar to focal radiotherapy, in a sense that the radio wave is concentrated to that one area, and that might help damage the tumor and kill it, thus stopping the cancer. Um, and so oncologists also prescribe chemotherapy. So this may be oral chemotherapy or venous agents. So that means like intravenous, so through the veins of the patient, depending on the tumor type or location. And also consider concurrent chemotherapy, radiotherapy for high-grade tumors. So concurrent means like occurring at the same time as something else. So chemoradiotherapy may also be continued with some other type of treatment. Then they may also help assess patient performance before starting treatments and monitor treatment response using follow-up imaging, so MRI scans, PET scans, and CT scans. They might manage treatment-related side effects, so fatigue, nausea, cytopenias, which is where blood component levels are lower than the normal range. So then they kind of take precautions to respond to those side effects. And then they coordinate long-term follow-up and surveillance scans. So after someone has, removed the tumor, the neurosurgeons have removed the tumor and the patient's feeling much better, they may, coordinate long-term follow-ups to make sure that the tumor doesn't reoccur again. Because as we saw, grade 3 tumors may reoccur again, and that might obviously have an impact on, they might need, surgical intervention again. They also work with palliative care teams for symptom control when needed. So palliative means it's a whole healthcare branch which focuses on alleviating symptoms more than curing them. So some disorders which we may have seen don't always have cures. So such as like genetic conditions or any type of brain tumors, which are very hard to get to without damaging the vital brain tissues around the brain. So for those type of cases, palliative healthcare professionals work together to kind of alleviate symptoms and reduce suffering of the patients. Radiologists, so they interpret MRIs, CT scans to detect abnormal tissue, edema, hemorrhages, and any structural changes. They also help identify tumor location, size, progression, and they compare imaging over time to monitor any changes, so evaluating like tumor growth or treatment response or to differentiate reoccurrence from like treatment related effects. So they help determine if surgery is possible or if it's needed, and then they kind of advise on the accessibility of the tumor and potential risks based on where it's located compared to any like critical neurological structures. And they also help provide imaging guidance for like biopsies and imaging findings at the MDT meetings. So if they find that the patient has a tumor or what type of tumor it is, then they obviously have the responsibility to talk about it, to present it to the MDT meetings. So then the other healthcare professionals can decide what to do next. Then we have clinical nurse specialists and allied healthcare professionals. So clinical nurse specialists, so also known as CNS, they act as the patient's key workers. So they are the main point of contact for any questions, any concerns, or any like care coordination. They provide emotional and practical support. So they help families and patients understand diagnosis and treatment options. And so they kind of act in the empathy side of the role, making sure that the patient feels, the vulnerable patient feels comforted and make sure that they're taken care of. They also coordinate appointments and care, and they explain treatments and possible side effects to make sure that the patient is making the uninformed decision. And they support families and carers, providing education and signposts to kind of support services. Then we have allied health professionals. So this is a big word for different types of healthcare professionals. So some of them being physiotherapist. So they provide mobility, strength, and rehabilitation after surgery or treatment. So obviously after surgery, the patient is quite bedridden, and to get back to their normal quality of life, they may need help from physiotherapists to kind of get their mobility back. Then we have occupational therapists, so they help patients adapt to daily activities and maintain independence, which obviously improves their quality of life. Speech and language therapists, they assess with communication or any swallowing difficulties caused by the tumor or any treatment that they went through. Now I will hand over to Anastasia, who will go over the rest of the presentation.
Okay, so now we're going to move on with surgical techniques in neuro-oncology, focusing on craniotomy, awake craniotomy, and tumor debulking. Okay, so the principles of brain tumor and surgery. So surgery is a key part of treatment for many brain tumors and is often the first step of management. The aim is to remove as much of the tumor as possible whilst preserving normal brain function, and this approach is known as the maximal safe resection. The extent of the tumor removal can influence symptoms, prognosis, patient survival, and modern neurosurgery uses things such as MRI guidance, neuronavigation, and brain mapping to improve surgical precision and safety. Okay, so now we're gonna talk about the craniotomy for tumor resection. So a craniotomy is the most common operation used to remove brain tumors, and a section of the skull is temporarily removed to access the brain. Then the tumor is carefully removed using specialized instruments and imaging guidance. And then it's the surrounding healthy brain tissue is preserved as much as possible. And then lastly, we have the skull is then replaced and then secured with small plates or screws. And on the image below, you can see basically the whole process being carried out. So we have the incision and then the scalp being taken apart, and as mentioned previously, it's being preserved as much as possible. And then we also have the skull being removed, so then we can get access to the brain and then do the tumor resection. So that's the process of craniotomy. Okay, in terms of awake craniotomy and brain mapping, so an awake craniotomy is used when a tumor is near areas controlling speech, movement, or memory. And the patient is awake for most of the part of the procedure, so brain functions can be monitored in real time. And so, for example, if the surgeon essentially is in an area, for example, where it's kind of controlling speech, for example, the surgeon might ask the patient a few questions and kind of get them to communicate with the surgeons to see if the areas that the surgeon is stimulating are still like allows the patient to still perform simple tasks. And then this helps identify and avoid critical functional regions, and it allows for safer tumor removal while preserving essential brain functions. And awake craniotomy is used when tumors are near speech areas, as I mentioned previously, motor cortexes, sensory areas, and language or memory centers. Debulking surgery. So, debulking surgery is performed when a brain tumor cannot be completely removed safely. And instead of removing the entire tumor, the surgeon removes as much of the um, tumor as possible to reduce the tumor size, and this helps relieve the pressure on the brain and improve symptoms. And it can make other treatments such as radiotherapy or chemotherapy more effective because essentially the tumor has shrinked in size, so it makes those treatments act a bit faster. And although debulking does not cure the tumor, it can improve quality of life and survival in some areas. So as you can see in the image, um, on the right, you can, sorry, on the right, you can see that it's the before surgery, the tumor is quite big, but then after the surgery, the tumor is basically little to nothing, is basically gone. So you can see how debulking surgery is really effective. And the benefits of debulking basically include reducing intracranial pressure, improving symptoms, supporting further treatment, and improving quality of life. Okay, so now we're going to move on to non-surgical management of brain malignancies. So non-surgical management for brain malignancies. So non-surgical treatments for brain malignancies aim to relieve symptoms, control tumor growth, and improve quality of life. Why are they used? Why are they used usually? So they're used because of the location or accessibility of the tumor. So tumors usually are in delicate areas or in critical areas, and so some um some may be too risky to remove surgically. So the patient's health risks, so some patients may have other health conditions such as like high blood pressure, diabetes, and they maybe have comorbidities essentially. So patients' health risks may make the removal of that tumor from their brain more surgically more difficult than it may already be. And then we have tumor type and behavior. So slow growing tumors may respond effectively to non-invasive treatments. So it's better to um, maybe use radiotherapy, chemotherapy rather than surgery to remove some type of tumors, for example. Okay, so common non-surgical treatments. So we have first have radiotherapy. So radiotherapy can be used as primary treatment for certain tumor types, and essentially it's used to reduce the size of the tumor, and it may be used as a palliative treatment. And it is also used to reduce the risk of recurrence of brain tumors post-surgery. We also have intensity modulated radiation therapy, and essentially it's a three-dimensional um conformal radiation therapy, and they are both are some of the common types of radiation that are used to treat brain tumors. And this is an image of what radiotherapy is. is. We now have chemotherapy, and in chemotherapy basically uses cytotoxic or anti-cancer, basically drugs, to destroy brain cancer cells or slow their growth. However, this also weakens the immune system. So you may typically see that lots of patients that do receive chemotherapy also do have lots of side effects and may feel sicker than usual. So although it's really effective, it's not really great for the actual quality of life for the patient. So these drugs may be given orally or intravenously, and this option is often used along with other treatment options like radiotherapy. And the common type of radiotherapy drugs include temozolomide, procarbazine, carmustine, and lomustine. Immunotherapy. So, immunotherapy is also a method of treatment which uses medicines to encourage or subdue your immune system, which helps fight cancer, infection, and other diseases. So, the types of immunotherapy for brain cancer are adoptive T cell therapy, and this helps the immune system to create more T cells to fight diseases. And we also have adjuvant immunotherapies, which help boost the natural immune system or makes other immunotherapies more effective. And this is basically an image kind of like going through, kind of explaining what immunotherapy is. So essentially, we take the blood from the patient and we take out the T cells from the patient and they go through reprogramming, and so they can increase in size and grow population of T cells, and then we infuse it back into the patient so that the T cells are then able to eliminate the cancer cells and fight off any other infections. Now we're going to move on to ethical concerns in neuro-oncology. So in cases related to neuromalignancy, patients are often required to make life or death based decisions. And if the patients have gone through progressive cognitive decline, it may cause some patients to be deemed to lack capacity. And in these situations, concerns about the patient's autonomy are raised, and it is important to make sure that the patient's wishes and values are upheld, even at times where they may be subjected to neurological decline. In these extenuating circumstances, the neuro-oncology MDT should take a course of action in these patients' best interest alongside consulting a lasting power of attorney or significant family members. So, in terms of quality of life versus longevity of life, so in some cases, patients may be subjected to continuous prolonged treatment, such as multiple surgeries, chemotherapy, or radiotherapy. and which can be highly invasive and cause chronic pain, as we mentioned previously. So, some neuro-oncology patients may also experience behavioral conditions such as depression and anxiety. And acting in non-maleficence can be difficult in such complex cases, and questions have been asked about whether stopping such potentially debilitating treatments and switching to palliative care would be a more suitable alternative. But essentially making sure that the patient's quality of life is upheld is the priority, and also making sure that the patient is involved in that decision whether they would want to carry on such long life treatments or get into palliative care is up to them. Okay, so in terms of justice, healthcare disparities exist, and when it comes to accessing specialized care, such as advanced radiography and stereotactic radiosurgery, often due to the geographical or socioeconomic barriers, there may be limited resources in hospitals, and also and that may also cause difficult conversations about how they can be ethically distributed according to the patient's clinical needs, and prioritizing them with more than treatable options compared to others. So in these cases, it is highly important for the neuro-oncology MDT to facilitate early conversations about the patient's treatment plan to help minimize such disparities as much as possible. Okay, so lastly, we're gonna do the future of neuro-oncology, focusing on immunotherapy, AI-guided techniques, and fluorescence-guided surgery. Okay, so AI-guided tumor resection. So it's basically the use of AI assistance to basically assisting neurosurgeons during surgery. And then basically how it works is that it's preoperative scans such as MRI, fMRI, or DTI are analyzed by AI models, and AI creates a 3D map of the tumor surrounding brain structures, and during surgery, real-time data is continuously updated. AI helps distinguish the tumor tissue, the healthy tissue, and critical functional areas such as the motor cortex and speech areas. And the key applications with this surgery are surgical planning. So it helps with optimal entry point and safest path. So it basically allows the surgeons to kind of map out where they should get in and out without puncturing or um, ruining other parts of the tissue brain. We also have intraoperative decision making. So it helps the surgeons basically and the MDT within the surgical room basically make decisions in real time about what they have to do in within the surgery. And we also have predicting tumor margins beyond visible boundaries. So basically allowing the surgeons to kind of see what they cannot see, if that makes sense, and making sure that they are able to kind of reach the tumor as safely as possible. So clinical impacts are increased extent of resection, and then we also have reduced neurological deficits post-surgery. And then we also have more consistent surgical outcomes across surgeons. So essentially, it's definitely a better way to go about um, resections and tumor removals. Basically, so some users may be real-time imaging analysis, also tumor boundary detection and surgical planning. And some benefits are increased tumor removal accuracy, reduced damage to healthy brain tissue, and shorter surgery times. So there are some technologies used behind the AI surgery, and some of the technologies are advanced imaging integration. So, as I mentioned previously, MRI scans, fMRI scans, and DTI scans. So, with MRI scans, they're usually used for structural detail. fMRI scans are used to map the brain activity, and then DTI scans, also known as diffusion tensor imaging, tracks white matter pathways. We also have intraoperative guidance systems. So we have neuronavigation systems, which are GPS-like for the brain. We also have real-time imaging updates during the surgery, and AI compensates for a brain shift, so movement of brain during the surgery. So now we're going to move on to immunotherapy in neuro-oncology. And essentially it's basically it basically stimulates or modifies the immune system to recognize and destroy tumor cells. So we have and then essentially it's important for aggressive tumors like glioblastomas. So there's three types of immunotherapy. So we have immune checkpoint inhibitors, and essentially tumors evade immunity using checkpoint proteins, for example, the PD-1 or the CLTA4 proteins. And so drugs block these checkpoints, and it allows the immune system to reactivate. So for example, we have therapies such as the anti PD-1 therapies which block the PD-1 pathways. We also have the use of the CAR T cell therapy, and essentially is using immunotherapy to kill brain cancer, essentially. And as we mentioned previously, we take blood from the patient, we isolate the T cells, and then engineer them to make sure that they recognize the brain cancer, and then we grow them so that we can put them back into the patient and they can attack the brain cancer and destroy it essentially. And then we also have cancer vaccines, which are personalized vaccines using tumor-specific antigens, and they train the immune system to recognize tumor cells. So there's a few benefits of this, which are highly specific targeting, that they also have potential long-term immune memory, and they are less systematic toxicity rather than chemotherapy. However, there's also some limitations such as variable patient response, so not every patient is gonna respond well to these treatments, and there's also risk of neuroinflammation. Okay, so now we're going to talk about fluorescence guided surgery. So it's basically a technique where fluorescent compounds are used to make tumor cells more visible, as you can see in the image here. And on the specific wavelength of light, the tumor cells emit a distinct glow, helping surgeons to differentiate from normal tissue to the cancerous tissue. And the common agents are the FALA, also known as the 5-amino levolinic acid. We also have we also have some that are administered orally several hours before the surgery, and some are also taken up preferentially by tumor cells. So the purpose of this is to help surgeons distinguish between the normal tissue and the tumor tissue, and it helps with complex resections. And advantages of the fluorescence guidance is that it improves um, the extent of tumor resection. It also reduces the residual tumor tissue and enhances surgical precision. And the outcome is there's better survival rates in aggressive tumors such as glioblastomas. However, there's some limitations to this, and some of the limitations are that not all tumors fluoresce equally. So some tumors may show the glow less than other tumors. We also have so the fluorescence intensity can vary, as I mentioned previously, and then some require specialized surgical microscopes, and then also it does not replace the need for histological confirmation, so it cannot just be used as a final guidance to see what tissue are the tumor cells and what aren't. Okay, now I'm gonna hand over back to Serena for the interactive quiz.
Thank you, Anastasia. So I'm just going to go over some questions really quickly. They're multiple choice, so just make sure to answer as fast as possible because we are running over time and we still have the well-being presentation left. So, what is the primary goal of neurosurgical tumor resection? Is it A, remove the entire brain tumor regardless of any damage? Is it B, maximal safe resection? C, cure all the cancers in the body, or D, avoid biopsy? I'll give you like 10 to 15 seconds just to, um, you know, tell me what the answer is. Yeah, so I've gotten a lot of B's, and the answer is B. Which imaging modality is the gold standard for brain tumor evaluation? Is it A, X-ray, B, ultrasound, C, MRI, or D, PET scans? Yep, it is C. So MRI scans are used as the first step for scans, and then PET scans are used to kind of differentiate between a grade 4 tumor and a grade 1 tumor. A tumor is located near the speech area. Which surgical technique may be used? Is it A, awake craniotomy, B, craniotomy, or is it C, debulking surgeries? These are the three surgical techniques we went over. So, yeah, what is it? Okay, some mixed answers. Some are saying A, some B, some C, but it's actually A. So we need awake craniotomy to kind of make sure that whatever the surgeon does doesn't actually affect the speech area. So then the patient can kind of interact with the surgeon to kind of make sure that their speech is working correctly and that they haven't lost their voice or their ability to speak. Which treatment is commonly used after tumor resection? Is it A, antibiotics, B, radiotherapy, C, physiotherapy, or D, cognition and speech therapy? Yeah, exactly. It's B. So radiotherapy is used after tumor resection to kind of kill any remaining parts of the tumor. Brain metastasis is most commonly originated from A, skin infections, B, lung, breast, or melanoma cancer, so skin cancers, or is it C, bone fractures, or D, liver cysts? Yes, exactly. It's B again. So this one was quite easy because it clearly talks about cancer here, and the other three don't really talk about cancer. They talk about other conditions. This one's the last one. So, a 60-year-old patient has large malignant brain tumor. So, the surgery could prolong life but may cause paralysis. So, what is the most important consideration? Is it A, the surgeon's judgment, B, the cost of the treatment, the surgery, or C, is it patient values or and like quality of life, or D, resources availability, or E, family opinion? Yes, it's C. So obviously, patient values and quality of life is the center of all healthcare, and not just neurosurgery. All healthcare professionals, their main motive is to work for the patient's best interest, and that comes with medical ethics and the six core values of the NHS and the seven guiding principles, which we will have a seminar on in the future. And so that is the most important consideration. It depends on the patients themselves and the quality of life that the patient may have after surgery, if it may cause paralysis. Okay, now I'll hand over to Silver just really quickly to go over the well-being presentation.
Okay, so the wellbeing presentation is going to be on navigating imposter syndrome. So, what is imposter syndrome? So, imposter syndrome can be a psychological pattern where an individual doubts their achievements, feels like a fraud despite any evidence of success, and it's pretty common within students and also high achievers. So, what leads this to happen? Now, this can happen a lot due to high expectations from yourself or others, and also a lot of comparisons, the idea of perfectionism, and also a fear of failure. There's a lot of common signs that you may be struggling with navigating imposter syndrome or maybe having this, for example, feeling as if you don't deserve success or attributing achievements to luck instead of hard work and determination, and having a fear of being found out. So, being found out that you are a fraud or that you don't deserve to be here, even though you have worked really hard, and overworking just to prove yourself and to prove to you that you belong here. Now, how does this affect the mind? It can lead to increased anxiety and stress, a reduced confidence, negative self talk, and difficulty accepting praise. So, all of these can have really bad negative psychological impacts on you. Now, how it also affects behavior. Now, it can lead to avoiding challenges, so avoiding anything that you might find too hard as you believe you won't be able to overcome it, as where you got to now was just due to a fluke. It can be procrastinating, so putting off any hard tasks or even easy tasks as you feel like you're not going to be able to do it, or over preparing, so over preparing for a task due to the fact that you feel like you need to put in more effort than other people, or even burnout from overworking yourself too much, and also not applying for opportunities as you feel you won't get them and you don't deserve them. So, how do you break this cycle? So, first thing is recognizing that your thoughts are not facts. These are just things that you are trying to convince yourself. You need to work on changing this. So, challenging your negative beliefs, working on that growth mindset, and also tracking your achievements so you can see how much you have achieved and how much you have improved. And also accepting that mistakes are normal and that are a natural process of life. Now, what are some practical strategies to break the cycle? Talking to others about how you feel doesn't have to be a therapist. It can be talking to people who are your friends and family, talking to anyone you feel comfortable with, or even talking to teachers in school, or talking to any supervisors at university. Also, setting realistic goals, so things that are achievable and celebrating small wins, and practicing self compassion. So, actually understanding why you may not have achieved something you wanted to and why you have achieved things that you are currently dealing with, and then shifting your mindset. So getting that positive mindset shift and also a growth mindset, replacing words like I don't belong with I am learning to belong, I am learning to get here, and focusing on growth, not perfection. So understanding that everyone struggles sometimes and it's a completely normal part of life. Now, to conclude, in terms of navigating imposter syndrome is very common, it's manageable. The most important thing is recognizing it. You've recognized it, and now it's time to work on coping strategies that can help build your confidence over time. But that is the presentation on navigating imposter syndrome.
Thank you so much, Silver. So obviously a lot of people, struggle with imposter syndrome. Even the most high achieving people do. And yeah, it's a very prevalent talk. And surgeons especially, they may experience this during or after their surgery, like training, or like even before then. So it's quite important that we discuss these type of issues. I've sent the attendance form for this seminar, so make sure that you actually fill it out, so then we can know who is getting the certificate for the neurosurgery series, because it is coming to an end. The next topic for next week will probably be on functional neurosurgery, which is a whole other specialty, other field. And yeah, it would be quite interesting. But yeah, now that we're wrapping up neurosurgery, we're going to be starting off with another surgical specialty, which would be whatever you guys vote on. And yeah, so thank you for joining this week's seminar, and I hope you enjoyed it. I hope it was beneficial. And yeah, I'll see you next week. And if you have any questions, I'll be waiting here at the end to guide you on them or help you with answering them. And yeah, that's it from us for now. And we'll see you next week. Bye, guys.